everybody in. There were over 135 people in the waiting room, and they are still coming in. So let's give a brief housekeeping explanation. At the bottom of your screen, you can choose the language you feel more comfortable with.
Bottom of the screen, you can select Portuguese, English, or Spanish. Você pode selecionar a língua português.
He's repeating the same in Portuguese. And it's in the toolbar at the bottom of the screen. So welcome, ladies and gentlemen. Welcome to this webinar organized by World Health Organization, the Department of Research on Reproductive Health, and the Pan American Health Organization on migration and sexual and reproductive health and rights. We know that ever since 2018, the Pan American Health Organization established that massive migration was a priority as a regional problem, as a health problem for the health agenda of the Americas, both sub-regionally and regionally. In December 2022, about 7 million refugees and migrants from Venezuela had already quit their country. Almost 6 million had already gone to some other country in Latin America and the Caribbean. In 2020, it is estimated that there were 715,000 refugees requesting asylum from Central America, Mexico, in their way to the United States. Since January 2022, there was a strong increase of this migration, which could give rise to 500,000 migrants that need assistance. That is why we have decided, together with the World Health Organization and the Pan American Health Organization, to devote this hour and a half to sharing some of the research that were directly funded by the WHO, the Department of Research, that have been conducted in Latin America, and specifically in the area of migration and the access to sexual and reproductive health and rights as a priority in the provision of care. Today, we're going to be able to enjoy 3 studies conducted in the region. The panelists are going to talk about that more in detail. We're going to have some time for questions and answers, expansions of the information that will be shared by all of you. We already have 160 people by now included in the list of participants. Each of you will have access to the information, and you will receive the scoops of the special bulletin of our journal of PAHO devoted to this. Without further ado, we want to welcome you and request Dr. John Reeder, head of the science division of the World Health Organization, to give his opening address. John, please, the floor is yours.
Thank you very much, Rodolfo, and it's really a great pleasure to be here, both in my capacity as the acting chief scientist at WHO, but also as the director of TDR, one of the collaborators in this initiative. Today's webinar and the findings included in the supplement being launched here are examples of true research collaboration, a cornerstone of the science division at WHO. It's also great to be in the company of many colleagues from PAHO and researchers representing some of the groups addressing important topics relating to health systems response to address the sexual and reproductive health and rights and infectious diseases of poverty of migrants from the Americas region, specifically from Venezuela and Central America. When crises like these emerge, it's critical to swiftly respond to generate the needed localized and context-specific evidence that can then inform national policies. We need to understand what works and why, and what hinders the access to health among migrants, particularly migrants from Venezuela, which is currently one of the largest movements of displaced persons, and from Central America that has been experiencing these movements for years. Initiatives such as the one led by HRP with the support of TDR and the Alliance for Health Systems and Policy Research, PAHO, and ChemiCamp in Brazil have proven to be important in supporting the emergence of new data. Central to this call was the impetus towards strengthening research capacity, and through a real collaborative effort spearheaded by the HRP Alliance for Research Capacity Strengthening, country teams have benefited from training and mentorship from the broader HRP Alliance network. I know the task has not been easy, not only because of the topic of investigation, delving into the difficulties faced by populations on the move with myriad challenges, but also because the project hit the ground right as COVID-19 hit the world. And I congratulate the 11 research teams across the 8 countries for their endurance, resilience, and commitment to improving the lives of migrants at this difficult time. Having representatives from the research teams from Latin America and the Caribbean is a great honor, and they are best placed to tell us about how these issues impact their region. I look forward to hearing from partners and colleagues and to see the results included in the special supplements being launched, translated into action and strategic thinking for region and beyond. So many thanks for inviting me to take part today, and I'll be listening with interest. Thank you, and back to you, Rodolfo.
Words. Y ahora le pedimos por favor al
And now we request Dr. Ciro Uriarte, the Director of the Health Emergencies of WHO, that in the name of the organization may give his address. You're muted. That's okay. Thank you, Rodolfo. It's a great pleasure. It's a privilege, rather, to be at this meeting, because it is not often that we find the linkages between research and evidence and how that translates into concrete actions. And migration has always been there, and it will continue to be there in the Americas. And of course, most countries in the region have, at one time or the other, either have received or sent migrants in many cases. Now we see that there are some countries that are transit countries. However, the massive migration that we've seen in recent years, mainly from some countries of the region, have intensified the challenges for the country's health services. And of course, this is a multi-sectoral issue. So migration from Mesoamerica to Mexico and to the United States and Canada, and migration of from Venezuela to the neighboring countries in South America and the Caribbean are events that have highlighted the need to protect the health of migrants as well as the health of the communities of destination. In that regard, there have been a very important initiative. This was already mentioned by Rodolfo at the beginning. In 2018, in late 2018, the Ministers of Health of the Americas got together in Washington to discuss this issue and to somehow jointly approach these challenges that have to do with all the region. And with COVID-19, these challenges multiplied, and some issues were unacceptable, discrimination, and with discrimination and huge challenges in the countries that got exacerbated. But at the same time, we've seen that many in this population, as they lack quick access to health services, were in jeopardy. At the same time, if there are people that suffer conditions or diseases and do not receive timely care, of course, they are also a risk to the population of destination. In that regard, one of the issues that the Ministers of Health identified as priorities was the strategic line to improve access to health services for migrants in terms of developing protocols and establishing actions to ensure monitoring and especially in the case of sexual, reproductive, and mother and child health. This was a decision by the ministers. However, knowing the size of these problems and how to find the best ways to respond to these challenges is an element that today that we're going to analyze in this webinar in detail. We have research and results that are very important, and I'm sure that many more will follow in such a way that both attention, both specialized care and primary care may have very positive results. So I wish you to participate in this webinar, to pay close attention to the presentations, and once again, to be able to translate evidence into practical actions. And that is the key objective of PAHO, WHO, and of course, the countries in the region. Thank you. Thank you, Dr. Ugarte. Thank you for motivating us to participate and paying attention to what we are going to be sharing today, that are original informations, a real scoop. The call in Latin America and the Caribbean was led by the special program for the development and training of human reproduction of UNICEF, UNDP, and the World Bank through the HRP for strengthening the local research capacities, as John said a few minutes ago. This collaboration was done with a special program, research and training of tropical diseases, TDR, as John pointed out, the Latin American Center for Perinatology, Women and Reproductive Health of CLAP, PAHO, to further strengthen the hub of research of the HRP Alliance in the research centers and reproductive health of Campinas, semi-camp that will be represented by Dr. Luis Bahamondes, whom we thank for his commitment. In the future minutes, Vanessa Brizuela, Technical Officer of HRP Alliance, will let us know a bit more about this initiative, its origins, its first steps, and how we managed to summon a significant number of researchers in the region. Vanessa, please, the floor is yours. Thank you, Rodolfo. Thank you all for being here. I'm going to give you a brief presentation, and I hope everything works well. I'm Vanessa Brizuela, and I'm representing the Department of Sexual and Reproductive Health and related research that has this special program. I will call it HRP in the rest of my talk because I'm used to saying it in English. Today, I'm going to tell you a bit what the process was like for this initiative and these special subsidies, grants for research that was led by the HRP Alliance, but together with a number of players that were mentioned both by John and what I'll mention again later. Let me start by giving you the background of this proposal within the special program, that it tends to strengthen the capacity of research at the center of the work of HRP, and its mandate is to lead in research in sexual and reproductive health and rights, and to leave installed capacity and research as part of the program. Starting in 2016, the figure under which we have included the activities that are related to the strengthening of the research capacity have been under the HRP Alliance. This alliance gathers a number of players to conduct research on sexual and reproductive rights and strengthening capacity, including regional and country offices of PAHO, collaborating centers, beneficiaries, either personal or institutional research collaborators, and the HRP regional centers or hubs. This alliance is based on three big pillars in collaboration and this dual function of investigating and strengthening the research capacities and the knowledge transfer so that all the knowledge may result in public policy for the benefit of the population and in a framework of sustainability. Today, I'm going to specifically talk about one of the activities that we have worked with, that is the special grants for research on emerging problems. In 2019, what gave rise to this call was sexual and reproductive health and rights and migrants, very specifically in the Americas. Why? Why did this matter? On the one hand, because ensuring the access to migrants to the sexual and reproductive health services is a public health priority, and very specifically women and girls, as well as individuals in the LGBTQI community and sexual minorities are affected when there's a vulnerable situation. And on the other hand, as was mentioned by Cito and John, we needed to have specific evidence for the context where things were going on of these migrators, and it should be generated locally and be related with these aspects of reproductive health. Our effort did not come out of the blues, but it accompanied what many people and UN agencies were already doing. And here I'm showing some of the documents, some of the guidelines of action that were happening when the call was made. So, with our joint efforts, we called our colleagues of the alliance and the club, Semicamp, that is the regional center or hub of the HRP Alliance, and colleagues of HIP. We got all together and we thought of this idea of calling for research proposals to to have a comprehensive view of this, including infectious diseases, especially targeting women and children as a response to this migration process that was taking place. The process of assessment and selection of the proposals was evaluated not only because of the scientific quality, but also because they integrate activities that strengthen research capacities as a key part of the research projects. An example has been incorporating researchers among junior researchers in their teams. For the selection process of the proposals, we put together a selection panel with representatives of all the agencies and groups behind this call, and each proposal was evaluated by two people independently, one internal to these groups and an external one that was called to participate on this topic. The last requirements that all projects had to go through was to have an ethics approval of the local committees and the ethics committee of PAHO. It's worth emphasizing the issue of strengthening the research capacity. This is a core item for the HRP Alliance. It's one of the elements that we use to assess the proposals, but also through the Senecamp as the regional hub. Not only did they execute the funds, but they followed the process and provided direct support, giving access to courses and training and support from the time that the protocols, research protocols were being prepared until the results were published. And they were published in the special bulletin that we are giving you today. Let me give you the timetable. The call was launched in October 2019. That we received 66 proposals. We chose 12 by February 2020, and we trained the people starting in that time. But a key thing is that the announcement of the winners was just a few weeks before the start of COVID-19. And you may imagine that this was highly disruptive. On the one hand, it interrupted research and the ethics committees because people were working with other kind of research, or they had to use their forces. There was an overload of protocols for the ethics committees. We had to change the protocols on the one hand to adapt, for instance, data gathering, because it needed a personal contact in many cases. On the other hand, the areas to be covered, there were some projects that required moving around in the country, going from cities to cities, and that was difficult because of the restrictions that were implemented as a response to the pandemic. Finally, of the 12 projects selected, there were 11 that were executed. One could not proceed because of the pandemic. There were 3 in Colombia, 2 in Mexico, 1 in Ecuador, 1 in Peru, 1 in Brazil, 1 in Dominican Republic, 1 in El Salvador, and finally 1 in Guatemala. I do not expect you to be able to read everything in the slide, but let me tell you that these 11 projects were executed, implemented, and the results will be presented in the special supplement that we are launching today. You can already see 7 of these articles in the website. The remaining 4 will be published in very soon, days, weeks. And today we're going to read the results of 3 of those projects, 1 from Brazil, 1 from Colombia, and 1 of Guatemala. Let me finish by sharing some lessons learned with this proposal. First of all, I wanted to highlight the importance of having locally generated evidence, not only because of the impact that it has on the healthcare systems, but also the public policy that may stem from this evidence, but also to leave research installed capacity, especially in the field of sexual and reproductive rights. This is a great lesson learned, and this is one of the things that I'm more pleased about in seeing the results of this process. However, there are other things that we learned from the results of these studies. On the one hand, migrant persons face multiple barriers in the access to health, to sexual and reproductive health services. Now we have concrete evidence that some of these barriers have to do with geographical transportation, stigma, and discrimination. They have to suffer the information and the lack thereof, or language differences. On the other hand, we learned that there are some things that offer opportunities for migrants. On the one hand, we have inclusive policies, even in the cases where they are not fully implemented, and some of the studies in the supplement highlight some of such constraints. But on the other hand, also because of the access to sexual and reproductive health and rights that include abortion services, maternal health, contraception, and comprehensive care for STIs. Let me finish just giving you the background. Our results complement and confirm what was published yesterday in the global report on migrants, but at a local level. And a few days ago, they published this document on the experiences that have arisen to give a response to the need for promoting health of refugees and migrants. Finally, I wanted to thank you. I wanted to thank not just the people that are with us in the panel today and the webinar, but all the research teams of the 11 groups. And we invite you to visit the website of the supplement, where you'll have a chance to read all the articles that won't be mentioned today in the panel. I also wanted to thank the people who revised the proposals in 2019, because that was a key thing to decide which projects to fund. The Semicamp team that was absolutely instrumental throughout the process, especially Luis Bahamondes and Nia Satanelli, that gave support to the 11 countries, but also to us in Geneva, and the two people in the ethics committee, Pajo, Calasainz, and Marcinil, that supported us at the beginning, and not a minor thing with the advent of COVID, and my colleagues who were part of this initiative. I am representing my colleagues of the TDR Alliance at RP, and as well as Rodolfo at CLAP. So I now give you the floor, Rodolfo. Thank you. Well, thank you. Thanks a lot, Vanessa. And now we have a clear idea what the process was like, what was selected of these 66. 12 were chosen, 11 made it until the end, and now I am very proud to present Damian Vasquez, who's the editor of the Pan American Journal on Public Health, of PAHO, and where this supplement that is being launched today will show us these 11 projects that made it to the end. To publication. This, in a way, certifies how we managed to transfer the information and do this that Vanessa stated was the local capacity, increase local capacity, improve, enhanced capability. And this is shown in the supplement. So, Damian, could you tell us a bit more about this supplement that you're launching? Thank you, Rodolfo. Good morning, everyone. Could you confirm if you see my screen, if you see my presentation? Yes, we see you very well, and we can hear you very well. Yes, indeed. Thank you. Well, I want to thank you all for being here. And in this very brief presentation, I'd like to tell you a bit about the importance of publishing the results of research. And I'd like to say that from the perspective of the Pan American, the Journal of Public Health. We turned 100 years old, and that for a public health journal is an absolute hallmark. And it's available to all the countries in the region. It publishes articles in Spanish, English, and Portuguese, and of course, it is free of charge and of open access. Sometimes in the communication workshops, people ask, why should we publish? And the simple response is because if you don't publish, you don't exist. What is not published doesn't exist. Probably in the 1500s, the sexual and reproductive health rights were not studied, but people studied human pregnancy. And we know this was the case because Leonardo left his writings and his pictures of what was known at the time of human gestation. And what today the surgeons know was was built upon the knowledge that was recorded in books of the 1500s. And let's fast forward 500 years ahead, and we see the role of scientific journals that we have available. And we can say that the paper of a journal translates what you have at the left to what you have at the right. The results are evident and visible. However, I would say that the most evident thing is not the most important thing. It's clear that a manuscript is an information that has not been checked, edited, and while the article has been peer-reviewed, and therefore its quality is better and it's been edited. However, in my view, that's not the most important thing. The most important thing is that the manuscript is just a manuscript with information that is shared among a group of authors with a journal, and absolutely nobody else knows the results of that manuscript. A scientific paper or article is a piece that is published, and it is broadly available to decision makers, authorities, and the general population. And it is here that this information turns into health actions, and it is here from where we take off with the virtuous cycle. Why? Because the academic our community can use those results as bibliography, as literature, and to build upon it for new research. Healthcare professionals sometimes change their guidelines for diagnosis or therapy based on the information published, and medical practice improves. Decision makers in turn may inform on policies, laws, or regulations based on that research, and that changes the dynamic of the healthcare systems. And finally, the general population may also have knowledge about this research and become better aware of lifestyle changes that are healthier. Some of these transformations are not direct, but they go through other players, including people who write guidelines or even the media. But in the end, sooner or later, they reach the communities mentioned here. I just wanted to invite you to visit our website. In the mid of the page, you'll see a sector where you have the special issues, and there you'll see an image like this one that gives you access to the website for that specific issue. As you see here, the articles on a number of topics, a number of countries, and in the Spanish side of the site, you'll see a link to a podcast that gives an account of how this supplement came into being. Finally, let me tell you that, as sometimes we say in the journal, that the publication is a teamwork, it's a joint effort, and I thought of giving a brief account of the number of people who had any manuscript in their hands or in the computer. So we assume that there were 5 authors in a manuscript. There were 3 editors, translators, librarians, and well, you can count up to 25 people that were directly involved with a single manuscript. If we multiply that times 11, we are speaking of 300 people or more. In addition to the institutions that were mentioned that gave their support in the programs and giving funds for this initiative. So we just want to thank you all those who participated in this endeavor, and everybody here connected, showing their interest. Thank you for your attention. Rodolfo, I give the floor back to you. Thank you, Damian. You were absolutely clear. And today we already have the scoop. It's launched. The information of the communications are available. There are questions in the chat, people asking where the information can be obtained. Damian has just said it, so thank you for that. Of these 11 papers, all will be in the supplement, and we upload them as the editorial process and peer review processes are completed. We already have 7 of such publications available, and just as by way of example, we're going to present 3 they represent a broad range in their topics, and they are geographically distributed in quite an equitable manner. So we are going to be able to see, just as an example, we're going to be able to see these 3 pieces of research. Let's start with the first. We're going to try to respect the 10 minutes for each actor. Let's see what were the barriers and facilitators for the diagnosis and treatment of HIV and AIDS and syphilis among Venezuelans in Brazil by Sonia Vivian de Jesus. You can go ahead, please. Please share your screen. Good morning. Good morning. So I'm going to present strategies for coping with HIV and syphilis in Venezuelan women in Brazil. We know that today we have about 281 million migrants around the world, and the Venezuelan migration continues to be one of the largest, 6.8 million refugees and migrants from Venezuela around the world. including 700,000 Venezuelans that entered Brazil as of 2022. Now, as to HIV, in 2021, 38.4 million people were living with HIV around the world in Latin America and the Caribbean. 2.1 million people had HIV. As to syphilis, 12 million people around the world in 2021. There were 167 new cases of acquired syphilis and 34,000 cases among the pregnant women in Brazil. From January to June 2022, Brazil registered about 200,000 cases of syphilis. The objective of our work was to describe the perception of Venezuelan women on the access to health services, health diagnosis, and treatment services for the treatment of HIV, AIDS, and syphilis in Brazil. The method, the study design, it was a descriptive study, exploratory study with a qualitative approach. The scenario was the municipalities of Boa Vista in Roraima, Manaus in Amazonas. And the subjects of the research were Venezuelan women diagnosed with HIV and or syphilis in those municipalities. The exclusion criteria were participants whose health conditions made it impossible to be interviewed, or if people refused to participate in the research. Part of the recruitment was done by the healthcare professionals that gave services to those women in Manaus, in the HIV and syphilis centers in Manaus and Boa Vista, and this was done in the interviews were transcribed completely. We did a manual analysis and we analyzed the contents, categorizing the different interpretation of the data, as pointed out by Bardam. And the protocol of the study was approved by the Ethics Committee of Research Ethics Committee of the Federal University of Espírito Santo and the National Ethics Committee. So, as to the results, 40 Venezuelan women were interviewed, and as to their socioeconomic profile, 32 women declared themselves as being brown or black. 20, most of them were from 20 to 30. Only one had university education. We divided the analysis into two categories: the barriers, facilitators. The barriers had to do with the obstacles that women found and the difficulties when looking for health services in Brazil. So as barriers, we had the language, the cost, health, adverse reactions to treatment, and the COVID-19 pandemic. And here I want to highlight comments. A 34-year-old woman that said, when I got to my destination, I sought help because the doctors were not understanding me because of the language. This clearly shows a difficulty that is related to language. As to the health costs, we saw that there were costs of moving from one place to the other, because those people usually live in peripheral places and more isolated and remote areas. So displacing to the places was sometimes it makes it difficult for them to look for a public service, and they end up using a private center. So as to the adverse reactions, there was a 34-year-old woman who discontinued treatment because she was not feeling well, and because she vomited the pill. They were yellow and they were very bitter. So that shows one of the adverse reactions of the patients that end up leading the patients to discontinue treatment. And then the COVID-19 pandemic, we know that it was shown that the data were collected during the pandemic, and then we had to adapt things. One of the comments that occurred was, I'm not taking my baby to treatment because the closest health unit is closed because of COVID. They are not working, and I don't know the city. I don't know where to go. Well, that shows how the flow of care was interrupted in Brazil. Well, knowing that in Venezuela, they don't provide care in the same way. To provide primary care and secondary care, people were not familiar with the different levels of care, nor did they know where to go. As to facilitators, here we have the categories showing the positive experiences in Brazil. Those women had those differences. We have the single health system. A 21-year-old woman said, I'm very thankful not having to pay for health because in Venezuela we pay and in dollars. It's very expensive. The national policy for a comprehensive care is also a facilitator. For instance, the person who was diagnosed when she was already pregnant in Brazil, and she started her antenatal, and there she discovered controls, and there she discovered she had syphilis. So, and there were also significant facilitators. A 27-year-old woman said that she received the basic basket, and she received emergency care assistance. And here it became apparent that that assistance was available for Brazil for those people was very important.
Onde foi disponibilizado, inclusive, para essas pessoas em situação de migração.
This aid was handed to these migrant people. The health professionals also contributed greatly. And the comment says that health professionals in Brazil are good, very caregiving, and when there's something lacking or when I can't go for consultation, they come home for a home visit to know what is going on. This proves once again the commitment of the health professionals. Conclusions. The study described Venezuelan women's perception regarding health service access, diagnosis and treatment of HIV, AIDS, and syphilis in Brazil. In spite of being supported by the health system in Brazil, national policies for health for women, social care, and professionals committed in the service, the study revealed the need to further elaborate and improve the policies to go forward and overcome the hurdles for the Venezuelan women. The language barrier is very important. We have access to the health system. We have support for migrants to use the service. That's not enough. We need to overcome these hurdles these people need. The language barriers, different issues with treatment and regarding the pandemic that must still be solved. But we must consider how to act together with people, what can be done at local level to strengthen this care in order to manage to have strategies to overcome the language barrier in particular, because this is a handicap for both the health professional and the person receiving care. The difficulty is on both sides.
and it must be overcome by both. So thank you for your attention, and I am here. Thank you so much, Sonia. The ministers of health in our region have become committed to the elimination of congenital syphilis and viral transmission of HIV by 2030. So we must include this vulnerable population. We know that Brazil is a very large continent-like country, and it also has this impact of the migrant population. So thank you so much, Sonia, for your presentation. Now we will hear a second piece of research analyzing in Colombia barriers to access safe abortion in Venezuelan and Colombian migrants in Barranquilla, Colombia. Jorge Luis Acosta will share the summary of his research. The floor is yours. Good morning, everybody. Thank you, Rodolfo, for the introduction. Thank you for allowing me to participate in this panel. Our project is called Voluntary Interruption of Pregnancy, Sexual and Reproductive Health in Women Migrants in Barranquilla. Pedro is the principal investigator. They work in the Barranquilla University. We have a support from people in Mexico and from Johns Hopkins. I am working in the Universidad del Norte. I'm a teacher. We're all aware that migration of human beings are situations that increase social, economic, and gender inequalities, and there's increased vulnerability. This is when we're speaking of women. This is due, among other reasons, to the fact that migrant women enter with little social family support networks. There's discrimination, structural inequalities, economic dependence, and unemployment that may be important factors to increase these inequalities. In Colombia, the Colombian migration data starting in 2014 showed us we had close to 2,500 migrants from Colombia, and in 2018 we began to have over 1 million, and in 2021, 22, that was a time during which we built the research proposal. We passed from 1.7 to nearly 2.4 million men and women we currently have. This is the percentage of men and women. It's generally been with more men, but we increasingly see women coming together with the men. Currently, the figure has been inverted, 51% women and 49% men. In Colombia, we lack information regarding inequalities, regarding health and access to health services of migrant women. We have little information on sexual and reproductive health. And in spite of generating a response plan in the health sector, guarantees for employing sexual and reproductive rights has received less attention. Without documents, women can only access emergency health care. They have less possibility of having a formal job and have less access to health services. The Constitutional Court acknowledged the voluntary interruption of pregnancy as a fundamental right of women and depenalized abortion to the 24th week of gestation. But migrant women maybe are not aware of this. We have this possibility of using these or enjoying these rights, and this is both for Colombian women and migrant women. The main goal then was identifying the knowledge regarding voluntary interruption of pregnancy and barriers to access it and sexual and reproductive rights services in Venezuelan and Colombian migrants. We conducted a qualitative descriptive study with a primary source with women from Venezuela and women who had returned over 6 months in Barranquilla. it wasn't necessary for them to have requested voluntary interruption of pregnancy. We have two groups of women, leaders, social leaders, and active participants or beneficiaries of processes encouraged by these leaders. Interviews were conducted by a sociologist that forms part of the research group with experience in qualitative methods and knowledge of sexual and reproductive health. The interview was performed over the phone. This in relation to COVID, because during this period we were undergoing the peak of the pandemic, and this didn't allow for face-to-face interview. The average time was 1 hour, and they were recorded for later analysis. The guide was dimensional, and the emphasis is in effective access to voluntary interruption of pregnancy and sexual and reproductive health of migrant women is a basic theory, and we used quotations. We defined three mixed categories: sexual and reproductive health, voluntary interruption of pregnancy, and suggestions to improve services. Barriers to access were identified from the interview, and the analysis was done independently by two researchers, comparing them to consolidate. This project received the ethics committee approval from the university and Tahoe. All women participating provided informed consent, and we guaranteed the information to be anonymous. Findings: we conducted 20 interviews with 11 leaders, and 9 were Venezuelan migrants and 2 Colombians who had returned. Average age 53, 80% had been over 5 years living in Colombia, 50% has a special permit to remain, and 90% belong to a low social and economic level. We didn't find differences between Venezuelan women and Colombians who had returned, and leaders and those at Tuesday's services. It is provided by complementary information. In the first category, knowledge about voluntary interruption of pregnancy and sexual and reproductive health. Most are unaware of their rights to access these services. They don't know how to do it, not even family planning. Some fear attending this due to the irregular condition, and some because they don't know they have this right. They do not know that abortion is a right. There isn't good information for Colombians in general, and of course migrants due to their vulnerability, and they had received little information. These are some quotations from leaders. If you think that if you conduct abortion, you will go to prison. Attitudes regarding voluntary interruption of pregnancy. Most the interviewed women do not agree with abortion, but they agreed it was a personal decision of women, but they wouldn't do it themselves or to themselves. And this is a quotation showing it's a complex issue that could be seen from different standpoints. In some cases, it might consider abortion, as mentioned here, rape, for example. The third category, failures in provision of service. Women narrated failures whereby they didn't receive care due to lack of documentation. Some were victims of obstetric violence. This is an example. She had an issue during pregnancy. It was terrible. If it hadn't been for a friend, she might have died during a care. The participants made recommendations that are included in our conclusion: capacity building at educational level, campaigns on sexual and reproductive health, interruption of pregnancy, more information at community level so people can come there, to train human talent and migrant populations in particular. This is a summary where we have barriers to access, particularly interruption of pregnancy, knowledge about rights, attitudes to voluntary interruption of pregnancy, and failures in provision. Lack of knowledge of the legal framework is, of course, a major barrier. Lack of training in organizations, negative attitudes towards voluntary interruption of pregnancy in the women interviewed could lead to lack of transmission of information and the irregular migration status, access to paperwork, high costs, and inhuman care are important hurdles. The discussions barriers are similar to those found in other studies in Colombia regarding coverage, provision of primary care, lack of documentation is a significant barrier. Other studies have also demonstrated it's a fundamental factor to access services, lack of knowledge about sexual and reproductive rights. The same happens in Chile, Brazil, and Peru. And there's a challenge regarding lack of knowledge of this in migrants. The system should identify these failures or barriers and propose interventions to overcome them. We also find similar barriers in the paperwork where all the paperwork that must be done by migrant women to access medical care also are seen in Colombian women of similar social and economic level. We need access to primary health care to guarantee effective treatment for migrant women. There's lack of knowledge in relation to regulations for voluntary access to pregnancy, so there could be clandestine abortions. Migrant women require information about sexual and reproductive health and rights. We must focus on these needs, speak with leaders, and train the health personnel so they understand the needs of our migrants. Funding and special thank you to migrant women, the UNICAM team, the HRP Alliance, and thank you for your attention. Thank you, Jorge, for such a clear presentation, respected the time allocated. So these findings are very important for Venezuelan women arriving to Colombia, Colombian women themselves. Now we will hear the third example shared by Paola Letona on sexual and reproductive health of migrant women and children or girls in the Northern Triangle. You're muted. Thank you. Pleasure to be here with you. Now we'll share the result of our research. People have already mentioned contextualized information. They are aware that migrants are vulnerable throughout the process, and as mentioned, vulnerability is increased when we're speaking of women. Throughout migration, girls and migrant women are constantly exposed to different threats to their sexual and reproductive health. There is literature and evidence documenting the needs for sexual and reproductive health of refugee women and migrants, but we need evidence regarding their needs during the transit stage. So our goal for research was to understand the experiences of sexual and reproductive health of migrant women in reproductive age between 15 and 49 years from El Salvador, Guatemala, and Honduras during their trip to the US. We had these three research questions. What information do they receive regarding the sexual and reproductive health before leaving? What self-care behaviors and strategies do they use during their trip? And where do these girls and women seek care in the sexual and reproductive health area during their travels? The study was done in 3 departments of Guatemala. Although it was in our territory, we approached girls that were not accompanied and migrant women from El Salvador, Guatemala, and Honduras. This was a qualitative, descriptive study, and we conducted 39 interviews face-to-face conducted during the first 6 months of 2022. Additionally, we had participation of 1/3 of minors, 16 participations were from Guatemala, and the remaining were from El Salvador and Honduras. The age group of participants was between 15 and 46 years. Result, general description, decision. Migrants had this perception that the US was a better life. The reasons for migrating were mainly economic and emotional. However, as we're aware, violence was cross-sectional and drove forward these decisions. They had the need to migrate for these reasons, but also emotional reasons. They wanted to leave behind some things. They had violence, lost children, lost a family member, and they wanted to leave all this behind. The decision was personal. However, friends and relatives in the US were significant for the decision because they provided information of coyotes that could be reliable and also paid sometimes even for their rates so that they could migrate. Preparation after the decision was made, they didn't have much time to prepare themselves. Sources of information were mainly people who had traveled to the US before. That is, coyotes were the main source of information how to prepare, or relatives, generally males, in the US. The information received regarded what they had to take with them, what they didn't, sanitary towels, certain clothes and paperwork, mobile phone chips, but they didn't receive information about their sexual and reproductive rights, but they didn't have any knowledge of this. We had many participants traveling in different ways, and therefore the condition was very different. Most traveled together with coyotes, some in large groups, some in small groups, others spent some time in hotels from one to the other, but there were also some groups that sometimes had a place where they could be under a roof because they were also spending lots of time outdoors. I'm going to share some quotations from different participants to introduce the different sexual and reproductive health issues we explored in our study. Menstruation, menses, most had sanitary towels. However, they faced several challenges. If they run out of them, they stole them or received them from other migrants. And in some cases, the menses came beforehand, and this was attributed by them to the stress. And therefore, they adapted, requesting for sanitary towels if they had money. They purchased it from other migrants who used other materials such as socks, small towels, or cut their clothes to use it to retain the blood. However, several participants had the chance of seeing women who didn't have any money or other ways of containing the blood and saw them walking with the blood stains. Hygiene practices were minimal, particularly women that only had access to water every other day, even to wash their hands. Of course, they wouldn't be able to wash their genitals, so they spent several days without access to water, and they lacked privacy, of course, oftentimes because the group had to remain together, and they had to change beside the other migrants. And of course, we have men and women. Now we're going to speak of contraceptive methods. We had three sorts of behaviors, most prepared specifically for the trip because they realized that they might be raped. The mothers of migrant children were very aware of this, and many decided to take contraceptives or receive the 3 month injection and sometimes used pills. However, the pills were not considered very practical because they didn't always have water to drink them, or they could fall or be lost or stolen. Some didn't use other methods, but some had used other methods. Ultimately, the reason to use these methods was a fear of pregnancy. When we discussed sexually transmitted diseases, they spoke very little about this. We only had 2 participants who mentioned HIV, for example. Participants didn't report having emergency contraception or using it, but other migrants had the day after pill. There is sexual intercourse throughout the trip. Transactional sex does occur, according to participants, when a woman is without money or feels that her means to continue her trip are threatened. So oftentimes it's the coyotes themselves who offer this. One accepted transactional sex and 2 other migrants received the request. They denied it and had negative consequences. 3 reported sexual violence, 1 a minor. They were sort of touched. And then there are secondary reports from migrants in this regard. The silence of victims, but also witnesses, something that is demanded. So women don't seek help in the health services to care for this sort of emergency. Pregnancy women said that it was common to see pregnant women, and sometimes they traveled alone, although they had children under 5 years of age. They were exposed to many risks, for example, to falls, extreme physical activity, hunger, cold, staying outdoors. Many had bleeding, they felt pain. If they complained, they observed there were risk behaviors in pregnant women, such as drinking alcohol or accessing transactional sex. We also observed that pregnant women sometimes took pills and they thought it might be vitamins. Access to health services practically non-existent in these participants because oftentimes to the type of route there weren't any. The legal condition causes distrust in providers, and the coyotes didn't allow them to go out even to purchase something, and at least so to go to the health services. So they had to keep a low profile. Participants did have some conditions, for example, cold, but nothing serious. One lost a lot of blood throughout the trip and stopped at a hospital in Mexico. Very few had access to health services, and this occurred when they were captured by the migration authorities in the US. Apart from this, none had access to health services. In the discussion, sexual and reproductive health of children and women, particularly those traveling with coyotes, is compromised due to the travel conditions. Men's health and hygiene was a challenge for many due to economic difficulties and the disbalance in power. They are oftentimes exposed to vulnerable conditions where they must accept transactional sex. Occurrence of sexual violence is frequent and oftentimes has led to a naturalization of this perception of rape, and sometimes even mothers allow their girls to be exposed to rape. This is normalized. There's a lack of discussion of sexually transmitted diseases and HIV, suggesting they are not the fundamental concern for them. However, this is important in our approach. We need to access the sexual and reproductive services during the travel, and in the case of pregnant women, to access prenatal care, but this doesn't occur. To conclude, we observe there's this significant need to improve interventions throughout the previous phase to inform women about issues they will face and the risk they will be exposed to, and also provide them information about their rights, what can be done, and resources to care for their sexual and reproductive health throughout the trip, and particularly for girls and women traveling with coyotes, because during the trip, organizations don't approach them because they try to have this low profile and can't go out. Last, I of course wish to thank our participants who shared their experiences, the organizations and community leaders that helped us to identify potential participants, and the co-authors, Erica Felter-Kanker and Jennifer Wieder. Thank you. Wonderful. Thank you so much, Paola, for your presentation. And in the time we have left, I will request the two panelists. We have this wonderful panel, Dr. Luis Balmondes and Dr. Christian Morales, the PAHO representative in Venezuela. This wonderful panel will make brief comments, after which the floor will be open for questions to the panelists before opening the floor from all participants. The floor is yours, Luis and Christian. Good morning. Thank you, Rodolfo. Thank you, Vanessa, for the invitation.
Yo represento a
I
Semicambia,
represent Semicambia, the Gynecology and Obstetrics Department of Campinas University in Brazil. We coordinated these small grants. We also had a broad experience with Venezuelan migrants in the state of Roraima and Pacaraima and Boa Vista, that's the capital of Roraima. And we published 5 papers, 5 or 6, regarding the experience with Venezuelan migrants in the northwest of Brazil, in the frontier. Regarding the small grants, as you stated, Rodolfo, they were a challenge. We had over 60 requests, and we only had the possibility of allocating 2 due to budget issues. Of course, many people were a bit angry about this, and many people did not like to be left aside. Fortunately, we used
de revisión por pares externos.
External peer review, and this
Tuvimos esos 12 que, como tú dices, después resultaron en 11 por cuestiones de COVID-19. A mí me da cierto orgullo. Primeramente quería decir que Vilma Sotarelli, que está por
Vilma Sotarelli, who is around,
Vilma Sotarelli fue alma y
was
vida en este proyecto.
the real life force for this project, meaning that she really helped and produced Excel sheets and followed and monitored the projects. We corrected the papers before sending them to the PAHO journal. And I also wanted to mention Marcia Nice da Silva, our financial director, because it was a challenge for her to receive the money from Geneva and then transfer it to the different centers with all the difficulties, do exist in Latin America to transfer external funds. So this was a wonderful exercise for us, and the continuation of a similar effort made during the Zika virus epidemic in Brazil and other Latin American countries that we also coordinated, where we also coordinated similar research published in the International Journal and College of Obstetrics 3 or 4 years ago. So thank you so much, Rodolfo, Christian, and Vanessa, and all the PAHO and WHO people for this opportunity. Christian, the floor is yours. And of course, if you have questions for the panelists, because we open questions for the participants. Thank you also for the invitation. I've had the privilege of being representative in Mexico, so maybe I'm very exposed to the challenges of migration in a country of transit that is also a country receiving migration, and Venezuela that is a great standard right now of migration. These research initiatives are extremely relevant, and we greet them very warmly because ultimately this is a phenomenon that is not only particular in several of its dimensions, but lasts in time. Mass migration in Latin America isn't something transient, although we've had it for decades, and now with some special features in the past 5-8 years, and nothing indicates ultimately it will stop in the short term. Yesterday and today, this inequality gap between richer countries and others that have less resources, or even sometimes have a growing GDP, but with inequalities where there's an increase of people under the poverty line, that is one of the engines encouraging migration. Social instability and economic intrinsic inequality in the development models of most of our countries also encourages migration, and of course climate change that is increasingly significant and drives migration. So in the short run, we'll probably be exposed to the continuation of what we're seeing. Of course, not from the same countries and due to the same reasons, but we'll have important migration flows we will have to respond to, and of which we know little, and it is there where research is relevant. Venezuela historically was the receiver of migrants. At present, we still have in Venezuela millions of Colombians and significant communities from the South of America, Chile, Argentina, Uruguay, that found in Venezuela a land receiving them in the 70s and 80s, and even before. Spain and Portugal were important senders of migrants to Venezuela. This situation has totally changed. In December 2022, according to UNDP estimates, we had millions of Venezuelans who consider themselves refugees in different parts of the world. Colombia, Peru, Ecuador are countries that have the greatest burden, with estimates of over 4 million Venezuelan migrants in these countries. We also observe, and it's important, we stress a situation that is sometimes left aside or invisible in terms of the migration that occurs in the indigenous populations in distant rural areas, such as the Warao population in the Tamacuro axis, Trinidad and Tobago, Guyana, or even to the south, Bolivia and Brazil, as mentioned by one of the researchers we just had. They have certain conditions that are different and are highly exposed, for example, to prostitution, and criminal groups make the most of this. The features are characteristic because they belong to minority ethnic groups. The health and well-being consequences of migrants include, of course, a higher risk for sexually transmitted diseases, sexual and gender violence, abuse, hunger, and nutrition issues, as we've seen in the research we've had. The difficulty, and we shouldn't forget, to maintain treatment for chronic and degenerative diseases that we know are an important source of morbidity in our countries. So when people are being displaced, we don't have anti-hypertensive drugs and other baseline treatments that impact, for example, also in mental health. There isn't health without mental health. And if people are migrating, and in particular women and girls, are strongly impacted in terms of mental health, not only throughout the migration process, but many years later. And this is an extra pressure we must consider in the health services of the receiving countries. Barriers to access health during migration are of different forms at economic and cultural level, ethnic discrimination, a lack of knowledge, and capacity to form part of the existing plans in the countries of transit and receiving countries, sanitation, drinking water, and so on. Universal health, in other words, will not be reached in any country if we don't have a response to specific needs of migrants. And here the challenges are many. We must approach these health needs of migrants from the rights perspective is perhaps one of the priorities, guaranteeing treatments to groups that are moving for HIV, contraception, non-communicable diseases. Changes in the migration profile, we see more women and children migrating in Mexico. Children from Central America are increasingly a significant part of the total number of migrants heading towards the northern border with the US. But there we also see other populations, including, for example, people from Venezuela. Pressure on the health services is significant and competes sometimes with the capacities to respond to their own needs with the local population. And this is a phenomenon that must be approached from several standpoints, including the anthropological, to seek evidence to support public appropriate policies in the countries. After the displacement, we always have an issue that lasts very long in the receiving countries to integrate even at health level. So we need more evidence and research to implement measures that are essential to respond to migrants' needs. We are aware of them, but we don't know how to implement them and how to reach them more specifically. We need to strengthen health surveillance, monitoring information, standardize records to allow comparisons. Question isn't what to do, but how to do it. And here research must contribute to greater evidence. We need to improve access to the migrant population health services and reception to better identify barriers and develop public policies and specific protocols for disease management according to the representation of different communities and the health issues, to improve communication and exchange with the local population, to counter xenophobia, discrimination, and stigma during the travels and in the reception, to strengthen networks and alliances to promote and protect migrant health, adapt policies and programs and legal frameworks to promote and protect migrant health. It is there that we must make an effort in research at macro and state level, at middle and micro level, and indeed with different research goals at these levels. I end here. Next steps we consider in this scenario are that research be focused on these key issues, so it's useful to make visible inequalities undergone by these populations and take action. So we don't stop handing evidence and proof, but link this with public policies. And here, as PAHO, we have this advantage allowing us to use this evidence and carry it to decision-making fora between countries and within them, to integrate at sub-regional level to respond to this issue. Health must be considered as a right with a change in paradigm in the national health services. It's a human right for all, independent of the migration status. Sexual and reproductive rights and health are a comprehensive part of health, and access to it must be guaranteed to migrants. And this is still a public health priority. And we also need a multidimensional approach with a multi-sectoral collaboration, national level, together with regional and multi-country interventions. Thank you. Thank you, Christian. Well, that's a wonderful closure, very brilliant regarding next steps and an analysis of what we have. There's a request for information of how to the participation of NGOs. Pro Familia is an NGO in Colombia where research was conducted, and it's an excellent example of participation of NGOs. I'm sorry, the time is up, so we really thank all our participants and panel. Thank you, Dr. Bahamondes and Morales, for your very clear words. Dr. Morales, the truth is that we use your participation as a wonderful closure to conclude our seminar. We are aware of the role of PAHO in this line and the use of local evidence that will allow us to take the next steps as mentioned. I believe that the next step will be to accompany the implementation in countries of the intervention to reduce this poor access to the causes as mentioned. Thank you all. 250 people participating in our seminar. It's going to be posted, it's recorded. We'll have the PowerPoint presentations and direct access to the supplement of the Public Health PAHO channel. Thank you. Have a good day all. We're open to any requests. Thank you. Bye.